Hi, my name is Abdou Elhendy. I'm a clinical associate professor of medicine at the University of Wisconsin-Madison, Wisconsin, and a clinical cardiologist at Marshfield Clinic, Wisconsin. My presentation today was about non-invasive evaluation of patients with coronary artery stents. It is estimated that over 1 million people undergo percutaneous intervention in the United States, and coronary artery stenting has become the major procedure for non-surgical revascularization. However, in-stent stenosis can occur in up to 10% of patients, even with the implementation of drug-eluting stents. Symptoms can happen in 60 to 70% of patients, but they are frequently atypical. It's not justifiable to perform coronary angiography for detection of in-stent restenosis in all patients because of the associated risk. There are various non-invasive imaging modalities available to evaluate patients for in-stent restenosis. I discussed today the role of cardiac CTA angiography, which is a promising technique. Although evaluation of stents using that technique is more difficult than in native coronary arteries due to beam hardening artifacts and partial volume artifacts. With the implementation of newer techniques and imaging acquisition processing, accuracy improves significantly, that the test can be feasible in a large number of patients to evaluate in-stent restenosis. The current guidelines recommend the use of the test only in patients who have a stent with a diameter equals to or greater than 3 millimeters, and in patients who have a stent in the left main coronary artery. I also discussed the role of myocardial perfusion imaging using radionuclide imaging agents. It's widely available. It can assess myocardial perfusion and function. There is a certain incidence of false positive results that can be obtained early after the procedure. Metabolic imaging also is a promising technique. FDG SPECT can be used to evaluate vulnerable plaques and detect in-stent thrombosis in patients with acute myocardial infarction. The next topic was speaking about stress echocardiography, which does not entail the use of irradiation. It can accurately localize ischemia, which can be also a sequence of progression of coronary artery disease in non-treated vessels. Finally, I discussed the current guidelines for the use of multimodality systems to diagnose myocardial ischemia. It is important to address that routine testing of asymptomatic patients after stents is not generally recommended, and most of these tests are considered appropriate in patients who have cardiac symptoms such as angina or equivalent symptoms. And finally, I indicated that the use of a certain imaging modality versus the other should be based on individual patients, recognizing value and limitation of each technique in an individual patient. Thank you.